for the next session, I'd like to introduce and invite up to the stage Lynn, Woofe, Rebecca Lace from the Bolton Homeless and Vulnerable Adults team, and Samantha Dornay Smith. Specialist diabetes nurse and Queen's nurse Lynn Woofe, working with Rebecca Lace, has done fantastic work with the Bolton Homeless and Vulnerable Adults team to improve the care of those living with diabetes. The project has inspired a pathway project led by Samantha and funded by the Burdett Trust for Nursing, which was launched in September 2023. And it brings together specialist nurses, practice nurses, district nurses, and the homeless and inclusion health nurses to learn how to better support people living with type 2 diabetes and homelessness.
What they've just said is if...
Do you need a mic?
And I was like, oh,
so I'm just
interesting.
Popping up to say hi. So my name's Sam Dornay Smith, and as it said, I'm the nursing fellow for the Pathway charity, and the Pathway charity sets up and supports homeless and inclusion health teams in acute hospitals around the country. So some of you may have a Pathway team, but we also do national sort of quality improvement work in all sorts of areas around healthcare for people experiencing homelessness, and also other inclusion health groups, asylum seekers, refugees, Gypsy Roma traveller and whatever. And it was on account of a Queen's Nurses Forum, hearing about Lynn's work, that we decided to apply for the Burdett Trust for Nursing grant to take her work nationally. So just to give you that context before Lynn and Becky talk, but you'll hear again from me at the end.
I mean, do we think...
Hi, thank you, everyone. Oh, there we go. Okay, just to say I'm really nervous, so if I faint, just like have a drink and then I'll get up afterwards. So I'm Lynn Woofe. Sorry, failed again now. I'm Lynn Woofe. I qualified 41 years ago, and the majority of care I've delivered has been in the area of diabetes and cardiovascular disease management. I spent 27 years in general practice as a specialist nurse practitioner, and it was here that I became a Queen's nurse in 2008, became a nurse prescriber, and I also developed the Community Diabetes Champion Programme. And it's the champions that now support the health improvement practitioners in Bolton to deliver hospital sessions around diabetes awareness.
That's what I said.
I've worked in the diabetes team for the last 6 years, and it was in 2019 that I met Becky. It was a Friday night just before we closed our community clinic, and she came in with an insulin crisis. There was a gentleman who just come onto the streets. He was on insulin, but he didn't know what it was. He hadn't got any, and he didn't know how much he was to take. And while we were trying to work out what to do, he ran off. And Becky had to go and find him. So, of course, I wasn't able to help. And I spent that weekend worrying, and it was sort of triggering concerns that I'd had previously about how the homeless actually manage diabetes. And I guess, that was the conception of the idea of the programme. Our collaborative work, I just feel that we work really well together. However, it's the collaboration between the homeless team and my specialism, diabetes specialism, that has been the key to the progress that we've had with this programme and the achievements that we've had. And individually, I don't think we'd have managed to get where we have managed to get so far. And obviously, you'll see some patient feedback about the programme.
Can you hear me? Can you hear me? No? Yeah. Hello, my name is Rebecca Lace. I qualified 20 years ago. The majority of my career has been in community nursing. I spent 8 years in district nursing, and I've been with the homeless nursing team for the last 9 years. I've been prescribing for the last 6 years, and I qualified as an ACP last year. So just a little bit about our nursing team. It was initially set up in 2007 with 2 staff providing a 2-hour-a-week clinic in a church hall. We are an ACP-led nursing service. We've got 9 staff with various backgrounds in prison nursing, mental health, learning difficulties, children's and district nursing. We've got a wide range of bands within the team, and we've got 3 non-medical prescribers. We perform outreach to the rough sleepers, into the overnight shelter, to hostels, guest houses, on move-on and temporary accommodation, and into permanent homes. We also attend the Street Kitchen Weekly run by Homeless Aid UK. We perform in-reach at the hospital Monday, Wednesday, Friday, with Monday to Friday telephone support. That's for the hospital staff. We have a drop-in clinic with an ACP Monday, Wednesday and Friday, and that's accessible in Bolton Town Centre. Our MDT consists of the Rough Sleeper Initiative team, which is from the council, and they have housing support officers, forensic psychologists and a dual diagnosis nurse. The Rough Sleeper Drug and Alcohol Services Council and Greater Manchester Mental Health funded, and they have recovery coordinators and support workers, a neuropsychologist, clinical psychologist and nurse prescribers. And we also work very closely with our accommodation staff. So you can see we've got a wide range of good support there for people. We're an empathic, compassionate, experienced team, and we have an approximate caseload of 200 patients. So where were we before this quality improvement project? Well, our involvement in diabetes care was mainly with crisis management. We did perform random blood sugar testing on new patient assessments or for the unwell adult, but we would crisis manage our patients on insulin. We would, who presented without medication. We would prescribe if the evidence was there in the patient's notes, and we'd also contact our diabetic specialist nurses for support, especially if they had no GP. We don't do active administration of insulin, and this was referred to district nurses because we provide no weekend cover. And management of the diabetes was generally left in the GP care or the DSN care. And we weren't acting on or recording any of the 9 diabetic care processes unless requested by the GP. We found this project really insightful and rewarding, and we really enjoy working with Lynn and bringing a really outstanding service to our patients, making a real difference to them and their diabetes and overall quality of life.
Okay, so before I started the programme, I thought I'd have a look about what research was out there regarding homelessness in the realm of managing diabetes. And surprisingly, there was actually very little UK data. Globally, I read that up to 22% of people around the world experiencing homelessness have some form of diabetes. And over 40% of these homeless individuals have diabetes the blood sugar levels are far above the healthy target. They report difficulties managing their condition, and this is often related to access to food, access to medicines, storage of medicines, and the ability to monitor the blood glucose. And of course, competing priorities, of which diabetes isn't necessarily the main one on their agenda. And obviously this means that their condition and poorer blood glucose sugar control than the host populations is common. And people with diabetes or are homeless are obviously at much higher risk of developing serious complications like amputations, diabetes ketoacidosis, and early death. I'm sorry, it's my slide. Looking at how we managed to drive change through our service. So obviously I led the development and the progression of the programme with the support of the homeless and vulnerable adult team. And this, again, this collaboration has been key to the achievements. I drew together a multidisciplinary team to develop a steering group, and we continue to meet 4 monthly. The team members are myself, and we've got the homeless team lead, diabetes consultant, have retinal screener, podiatrist, hostel managers, the health improvement practitioner lead, diabetes community champion, and I have a member from the Health Watch charity. I developed a database, and this is to support audit purposes and to help to produce a future business case. I secured a point of care testing machine to enable us to carry out opportunistic HbA1 screening across hostel sites and in the community. We deliver hostel diabetes awareness sessions, and this is run by the health improvement practitioners and the diabetes champions. And with my link with Health Watch, as sort of an add-on that runs alongside the diabetes awareness sessions, I've helped to facilitate, alongside the GP Federation, cervical screening pop-up service at the ladies' hostel, and also bowel screening and breast screening awareness sessions to help to engage, again, the vulnerable communities, to engage with the national screening programmes. We've provided education via the Sanofi-sponsored Eden programme, and we've managed to train over 20 hostel staff across 4 sites. The emergency department screening for the HbA1c and lipids was facilitated by me developing a no fixed abode blood order set, and that is to use for people that declare themselves homeless attending ED and that they're going to have blood tests at that point. I've increased access to technology, and that's via blood glucose monitoring, Libre sensors and Dexcom for those that are suitable, and we've actually started 2 of our homeless patients using hybrid closed-loop insulin pumps. I've managed to achieve NHS England funding, and this has been secured in 2023, and this has enabled me to focus my work 1 day a week working alongside the homeless team, which has prevented me from doing an awful lot of work in my own time. And I've obviously supported the education of the homeless team colleagues, particularly in the management of complex diabetes like type 1 and type 3C.
So what challenges have we faced? Well, an increasing workload, as Lynn said, has led to more work being done in her own time, and this actually does require an additional business case to create sustainment for this project. Lynn's also challenged traditional practice templates with senior management who initially didn't recognise that this project needed a more flexible approach. She also received challenges from the hospital chief executives regarding complex patients' lengths of stays in hospital and from ED consultants whilst developing the blood order set, which actually took 2 years to approve. Our own homeless nursing workload has increased, especially with obtaining difficult bloods, regular monitoring of the patients and supporting insulin administration. So why is this an innovative model of care? Well, at the time, there was no comparable diabetes nurse-led service in England. We have an outreach approach with flexibility, and this is proven to work with the homeless population, and it was needed to reach these vulnerable patients. By integrating a DSN within a homeless nursing service has provided these patients with the intensive support, and like Lynn said, some of the patients have been sustained on high-risk insulin management strategies to help prevent deterioration or DKA. Lynn's also added in additional bloods which have proved to show depletions in vitamin D, B12 and folate levels, which have then been treated. And Lynn also, with her experience in cardiovascular prescribing, has managed to demonstrate improvements in BP, lipids and ACR. Okay, we'd like to just present one of our complex cases to you. This is a 41-year-old male who was diagnosed type 2 diabetic in 2019, and he has alcohol dependency. His HbA1c was between 93 and 108 when I looked at his records, and he was on oral medication. In June 2023, he had a relationship breakdown with his wife, and he ended up rough sleeping in his car and then had to move into a tent. He was eventually housed in temporary accommodation in August 2023 in a self-contained flat, so it wasn't a facility that we were actually actively going into. He was admitted in DKA in October 2023 and diagnosed by Lynn with type 3C diabetes from alcohol dependency. She then started him on insulin. During the management of his case, Lynn's prescribed a high-risk insulin management strategy to help keep him safe. So from October 2023 to July 2024, his HbA1c was reduced to 55, and with cardiovascular prescribing, Lynn's also managed to reduce his BP and his lipids. During this time, he did have numerous admissions, mainly due to alcohol relapses, but none of them were in actual DKA. We have a wraparound MDT, like I've said, and with diabetic specialist nurse Lynn, our own homeless team, the addiction team with psychological support and housing, that created a great support network for him. We advocated throughout for him, especially with housing and in particular with regarding a move that they wanted to make for him because they didn't feel he was managing in the self-contained flat due to his last admission. And yes, in part we agreed with that, but he also had his wife who was also trying to support him. And if they had moved him into the hostel accommodation, his wife wouldn't be able to give that same level of support. So we tried to hold off and said, look, just give us a few weeks, wait for this detox placement to come up, and then let's see where we are. And he managed to move from the flat straight into detox. He's now in a recovery home, he's sober, and he's got the mental health support he needs. And he's now also with his wife. So we'd like you to read this testimony. These are his words that he sent to Lynn via an email from the recovery home. Okay. So you can see the impact our collaborative work has had on his quality of life and his future well-being. So, what are the benefits of a collaborative team? Well, we're patient-focused. We have a flexible approach with individualised care plans, and this helps to build the therapeutic relationships. Our in-reach work at the hospital with the collaborative team, Lynn, leads to safer discharge planning and increased engagement post-discharge. And our outreach work, again with Lynn, for monitoring diagnostic tests and observations prior to Lynn's reviews leads to timely management and care. We have screening sessions for HbA1c testing for at the hostels and at the drop-in clinic, which leads to early diagnosis and care. We're also staff focused, so our own team's knowledge has really increased, our confidence and autonomy as well. And our team morale is high, knowing that we're benefiting these really vulnerable patients and making a positive difference. Has it gone off? Okay.
So these are just some slides we put together using the information that we'd gathered from our database. So this slide is just one of the demographic slides. So as you can see, the majority of our patients on our cohort are male, and the majority are white British. Currently, we have about 22% that have got other mixed ethnicities. Our age group is mainly between 31 and 60 years old. And as you can see, we do have some younger ones, and they do tend to be type 1s. We don't have any very young type 2s yet. The top box shows just reflecting national prevalence, that the majority of our patients are type 2. Currently, we have 25% that are type 1 and 12% that are type 3C, so that equates to 37% that are in the complex insulin management category, of which some of those we have to prescribe high-risk insulin strategies just to keep them safe. The bottom box is just showing, not unsurprisingly, that the majority of our patients are smokers, which obviously is a big marker for cardiovascular disease. This next slide is just looking at the completion of the 9 diabetes care processes. And as you're all aware, that everyone in the UK with diabetes should expect to have these completed at least annually. And not only completed, but actioned. And obviously, with the homeless population, we do know that they don't engage very well with the medical services. And if they're not engaging with the GP practice, they're not getting these completed. And more importantly, they're not getting them actioned, which of course means that this can increase the risk towards poorer outcomes. So the box on the left just shows, in comparison to the national audit data and the best figures that they'd got recorded pre-COVID, 2019 to 20, was showing that in the general population, about 45% have managed to have all 9 diabetes care processes completed. In comparison with the data that we've pulled off our database, at the time, 64% of our patients had all 9 diabetes care processes completed and actioned. 16% had missed 1 and 12% had missed 2, which I think is obviously quite overwhelming. This next slide is just looking at HbA1c results that we'd achieved. So we've got 2 boxes. The box on the left is just looking at those that had presented initially with HbA1cs under 100 millimoles, and the other box is showing those that had presented at first presentation had results over 100 millimoles. The blue box is the results on first presentation, so the first results that we'd taken, and the orange boxes are approximately 4 months later when we repeated the test. And as you can see, we'd improved across both categories. The biggest improvement we had achieved was those that are presented initially with HbA1c's greater than 100 millimoles. This next slide is looking at the metabolic parameters of blood pressure, urine ACR and cholesterol. And as Becky had sort of mentioned, with my years of specialist practitioner in GP practice, I've maintained my cardiovascular prescribing. So again, blue boxes results at the first presentation, orange boxes approximately 4 months later. And as you can see, against all categories, we'd improved on the results. The main improvement we'd achieved, obviously, you can see, was in the urine ACR, and that is directly related not just to improvements in HbA1c, but is the work that I've done improving blood pressures and cholesterol levels. This slide was actually put together by Becky, and I was quite impressed with this. She took a sample of just 5 patients that had been regular hospital attenders prior to them joining our programme, and of course they had diabetes. And she looked at the results, their attendances rather, for a matched duration before they came on the programme and after they'd been on the programme. And as you can see in this small group, we had reduced bed days by 59% and ED attendances by 66%. And again, you know, it's only when you're actually looking at this data that you actually think, oh, wow, we did all right there. So looking at how, you know, our work is perhaps helping to shape future services, not just in our own trust. Our model of care has been used for at the basis for a national Queen's Nurse Institute quality improvement programme, which has been funded by the Burdett Trust and is being managed by our friend Samantha Dornay Smith, and she will explain about this during her presentation. But she contacted me at the start of her programme and asked if I could be part of a steering group, and obviously I said yes. And we've helped to support 13 other nurses across England to start their own quality improvement programmes in this area of homeless and diabetes management. Again, with this work that Sam has been leading on, we've also helped to develop a Fair Health e-learning programme. Again, Sam will talk to you about this, but that's just been launched last month. Our collaborative team in Bolton have also helped to update the Groundswell Charity Diabetes leaflets, and these are available for people that are homeless around diabetes and its management.
Okay, so sharing best practice. Our multidisciplinary teamwork has been mentioned in NICE guidelines. We've also been asked to present our work to the Inclusion Services Learning Pathway, which we did in June. We're finalists in the Nursing Times Awards, and we presented this in September, and we've been asked by a consultant to present this work at the Clinical Leaders Network in December. Our evidence of success is underpinned by national recognition, which is highlighted by the development of the National Quality Improvement Programme, which Sam is going to talk about and showcased in these articles.
So just to summarise, our model of care has been nationally recognised, and it's been shown to be transferable and an adaptable model of care. And we've demonstrated national NHS cost savings while significantly improving patient outcomes. And our flexible approach and collaborative working has had a positive impact for patients and staff. And the patient feedback is representative of their perceived value of our programme and what it's had on their quality of life. Thank you.
There's not much you can say after that, is there really? So I will try and be quick. So just to say, so we were granted some money from the Burdett Trust for Nursing, and that led to a 15-month programme. Okay. And I've just been told I've got 5 minutes. So there was lots as part of that programme. Really important to note there were visits to areas of good practice. And just a shout out to Liverpool, the Brownlow practice, Juliet Palmer, who has also done an incredible piece of work there. I don't know whether she's here today. I will just move on. But just to say, we did have in April a meeting of lots of those nurses that have been doing improvement projects around the country, and you can see Lynn in the middle there. I just wanted to say one of the things we did was review some safeguarding adult reviews, because it's really important to understand where things have gone wrong. These were safeguarding adult reviews after death, specifically for people where the key issues were homelessness and diabetes. They're not easy reading, but they're in the report and the e-learning, and if you do have a chance, have a look. These people have died very early. I've put their names up there, and it really kind of makes you think about why we might want to do this. Just a couple of examples of other types of programmes that have gone on. So that's Emma Green there in Plymouth. She was actually focused on reducing admissions for diabetic ketoacidosis. And you can see that she ended up focusing on 24 patients with 107 admissions over 10 months. And the profile of those people was, they were female, under 30, lots of homelessness issues, mental health, addiction, and a history of being in care. And overall, you can see she reduced those number of admissions quite dramatically from year to year, using a case management approach of outreach, lots of CGM, psychology, and training to carers and hostel workers. Worth noting about St Helens, that's a different type of team. They are a specialist outreach team. They don't caseload. Their whole role is to go out and support, for example, mental health hospitals, addiction services, homeless hostels and care homes. So well worth checking in with that, because it's a different way of thinking, I think. So many insights on this programme. I think the really most important one is just to say that you are incredibly valuable. And if you can get out and link with the homeless teams in your area or homeless hostels or whatever, you will make a difference and you will save lives. And also, I will say the clinical network has been brilliant, and getting these people together. Just to say, the quality improvement tools are now freely available. Anyone can use them, so do get in contact, and they're also downloadable on the internet, and they include how you might talk to people experiencing homelessness about their experience of care. Just to shout out a couple of examples. So Salford, from doing one of the access audits, they've now started new education sessions, a monthly pop-up clinic. They've had a reset on CGM and who that can go out to. They're recording housing status in their clinic notes, and actually now across the hospital. So they've made a massive change to how the hospital will identify homelessness, and that's just come out of this project. And in Bournemouth, from doing the audit, they realised how few people they were seeing in this group. And as a result, Sam Riddle is now out half a day a week on the screening bus. So the programme has made a huge difference. This won't be new to you. People feel told off. They feel like they're being told to do things that they couldn't possibly do. And they feel it's really complicated and they don't understand. And these things have disengaged people after they've come to specialist care, not before. So it's really important to know that, and there's a lot about that in the training. And for example, this is Kelly. There's a lovely video from Kelly in the e-learning, but she talked as well about the fact she just spent 10 months in hospital. There was such an opportunity to teach her all the time. She didn't feel that she got that. As Lynn said, across the board, we've had some really big and clinical insights about type 3C diabetes, which is quite prevalent in this population, about the use of CGM, which I think a lot of people would think was unrealistic, adaptations to insulin regimes for people with addictions, identification and working around mental health, and we have some, a lot of, for example, eating disorders and overdose in this population. Lots of things about the need for nutritional and food security screening. There's loads of things in there. And just in regard to safeguarding, lots of safeguarding insights, but I just put this one up. This is actually one of Lynn's patients who Lynn managed to help be held under a deprivation of liberty safeguard after 156 attendances at A&E. Now, lots of people get very worried about dolls, but this is his response. I'm glad that happened. I needed someone to take control. And I think you need to think very clearly about self-neglect and the role of safeguarding with these patients. So, is that okay? I'm done. Yeah. So the outputs, there is a report, it's 160 pages long. You might not want to read 160 pages, I can acknowledge that, but there are lots of examples of different projects around the country if you are interested. There's an e-learning module, we've had really, really good feedback. It's free, you can do it in bits, it covers all of the different things that we've talked about. There's also some downloadable guidance on the Q&I website. And as Lynn said, there's leaflets for people experiencing homelessness on diabetes and how to manage it, an eye care leaflet, and the audit resources. There will be journal articles coming out, hopefully early next year. And just to say, I am now moving on to a 3-year project on end-of-life care for people experiencing homelessness. But I think there is a massive, there's massive potential to do more research in this area. There's just some research areas up there. I'm sure Lynn will go on to do stuff, but if anybody is interested in doing research in this area, do get in contact, because I'm sure we can try and support you, make applications and stuff like that. So that's it. Oh, and just to acknowledge the amazing steering group, of which of course Lynn was the lead. Thanks.
Thank you so much. That was very inspiring, and we've run so close to time. So we were just going to say if anybody has one question that they would like to ask, but you guys are staying around, aren't you, the rest of the day? So yeah, if they can catch you maybe on lunch break.
So I've got the questions here, but there's one that's come up a few times. Just in your case study, you discussed the high-risk insulin strategy. Can you tell us a bit more about that?
Hello. So obviously, the patients that we've got on the high risk were basal bolus patients, but they weren't managing it themselves. So there was 2 or 3 that we had. So I had to make sure that the basal insulin was Tresiba, so that with the knowledge that if they weren't going to take their insulin, that it was all right for a couple of days. And this again is the way that the homeless team worked, because I can prescribe it. There's no way I'm going to go out. I can't sort of see the patient. But Becky's team, again, above and beyond, would go into the patients, and they might see 2 or 3 times a week. And as long as they could get their basal insulin in, I'd done a sort of let's say, a novorapid or a true RP correction plan. So at the time, if their blood sugar was above a certain level, they would also get some short-acting insulin in. It's not ideal. It's not going to stop complications. However, it kept them out of hospital. And I can guarantee, I know hand on heart, that 2 patients are alive because of sort of these sort of strategies that we had to employ.
Thank you. Thank you.